So today we're going to be talking about rotator cuff tears. So first talking about the etiology and pathophysiology. So the rotator cuff is made up of four muscles: the supraspinatus, infraspinatus, subscapularis, and teres minor. The most commonly torn is the supraspinatus, which is the main abductor of the shoulder muscle. The infraspinatus and teres minor are used with lateral rotation of the shoulder, and the subscapularis is medial rotation of the shoulder. The rotator cuff tendons come together to form a capsule around the humeral head, and they are really used to abduct and externally rotate the shoulder and stabilize the humeral head in that glenohumeral joint. Mechanism of rotator cuff tears can be broken into two categories: intrinsic and extrinsic. Intrinsic is fiber friction and degeneration, while extrinsic is the forces exerted on the rotator cuff by other injuries such as the AC joint or other traumatic injuries. We all think about rotator cuff tears, we think about trauma and overuse mechanisms, but really there's also been studies that show smoking tobacco, diabetes, obesity are also related to an increase in prevalence and severity of rotator cuff tears. Specifically, tobacco use is shown to show a significant increase in rotator cuff tear prevalence and increase in the severity of rotator cuff tears. Dyslipidemia is also increasing the prevalence, and hypertension and previous cardiovascular events are also related to a significant increase in the severity of the rotator cuff tear. Another study also concluded that diabetes is an independent risk factor for rotator cuff tears. With over 30 million people smoking and 30 million people with diabetes, these are two very common prevalent risk factors that are modifiable and can help with the prevention and stop the progression of rotator cuff tears. Clinical assessment, so starting with symptoms: weakness in the affected shoulder, especially with performing activities of daily living overhead, brushing hair, putting a shirt on, getting dressed. Also, a hallmark sign is shoulder pain at night. When we're talking about athletes, it's important to look at more of a decrease in sport performance than just generalized pain. When talking about physical exam, there are two specific tests that need to be done. We usually start with shoulder range of motion. Rotator cuff tears usually have pain or limitation on active range of motion, but not much pain with passive range of motion. The empty can test is the first test that we can look at in respect to rotator cuff tears. It involves placing the patient's affected shoulder at 90 degrees abduction and then allowing them to complete internal rotation. Any pain with this is considered a positive test. The drop arm test is another test that involves full abduction of the arm and then slowly adducting the arm back towards the body. If the arm drops suddenly or drops after being tapped, it's considered a positive test. It has been shown in a couple different studies that the empty can test was the most sensitive and the dropped arm was the most specific. So these are two good tests when you're thinking about rotator cuff tears, but they're not very, very specific, which is where imaging comes into play. So for differential diagnosis in shoulder pain lasting greater than 6 months, you need to consider rotator cuff disorders, adhesive capsulitis, arthritis, or biceps tendon pathology. So in front of you is the picture of the MRI. So the arrow pointing to the little dark spot in the rotator cuff tendons, that's usually how they show up, a dark gray spot where it should be hazy, it's pretty defined. MRIs are commonly done for diagnosis, but also for surgical planning. They show tendon tear size, tendon retraction, and additional muscle atrophy. It also helps look at other issues that may complicate surgery, like soft tissue swelling, biceps tendon pathology, bone loss, or fatty infiltration. So it's a detailed image without radiation, but it can be expensive, so that's something important to consider. For conservative treatment, most commonly used NSAIDs, ice, and heat to help with inflammation. Once the pain is refractory to those, glucocorticoid injections can be used for pain control. The picture up on the screen shows how the posterior approach is done under the border of the acromion, and you point the needle towards the clavicle. The use of 4 or more injections within the same joint can lead to tendon deterioration, which prolongs healing, so that's important to let your patients know as well. It's kind of a temporary relief. Physical therapy is the most effective conservative treatment we have, and it's very important in patients, especially that are elderly. So, a study looked at physical therapy and tendon repair at 2 years out to see how the non traumatic rotator cuff tears did. The study did 12 weeks of physical therapy, and it showed no significant difference in the clinical outcome between PT and surgical repair. So, physical therapy is a good, effective initial treatment when dealing with non traumatic rotator cuff tears. The problem with physical therapy is that you have to complete the entire 12 weeks in order to achieve that effectiveness. The study showed that compliance with physical therapy drops 68% in weeks 7 through 12. So even though patients are starting to feel better, not in as much pain, it's important to keep them going to finish out those last weeks of healing. If the entire protocol is fulfilled, PT is effective in treating non traumatic full thickness tears about 75% of the time. And you can also see some at home stretches. Physical therapy doesn't always have to be multiple days a week. You can kind of make it to where your patient has the best compliance. Surgical options. So, surgical management is indicated in failure of conservative treatment, traumatic tears, and sudden loss of function. Surgical management is also used initially in young athletes because it's the best way to achieve maximum tendon strength for continued sport performance. Open repair is not really done anymore as arthroscopic has become more standard of care. These pictures are from an arthroscopic repair. Usually they use a 3-portal technique where the tendon can be visualized and reconnected through different kind of sutures and ports. Study looked and there were significantly lower re-tear rates after 5 years using arthroscopic technique. There's also improved patient ranked pain and improved shoulder function compared to the open repair. Although arthroscopic repair is pretty widely done now, there are risks and complications. So complications: tendon re-tear, worsening pain, infection, bleeding, trouble with anesthesia. Re-tear rate is the most significant complication, and that really depends on the size of the tear, the degree of muscle atrophy, and the other comorbidities the patient has. So it's important to remember that while the arthroscopic shoulder repair may not be a very intense surgery, comorbidities can really affect anesthesia and the complications related to that. So it's important to discuss that with your patient as well before deciding surgical intervention. All right. And here are my references. Thank you.